Preclinical left ventricular systolic dysfunction is common yet under-recognized in the community. It's been estimated that somewhere between 1 to 9% of the general population has this. Due to the absence of specific symptoms, preclinical left ventricular systolic dysfunction goes unrecognized and undertreated. My name is Dr. Anthony Kashu, and I'm a cardiology fellow at Mayo Clinic in Rochester, Minnesota. On behalf of Dr. Paul McKee and our team, I would like to take the opportunity to share our work that was recently published in Mayo Clinic Proceedings, entitled Artificial Augmented ECG Detection of Left Ventricular Systolic Dysfunction in the General Population. It is well known that the treatment of asymptomatic left ventricular systolic dysfunction can 1. Improve cardiac function, 2. Delay the onset of symptomatic heart failure, and 3. Improve the morbidity and mortality of patients. Now, given the increase in prevalence of heart failure, effective strategies are needed to detect preclinical left ventricular systolic dysfunction in the community. Now, unfortunately, current evidence is inadequate to support community-wide screening in asymptomatic patients. The use of clinical risk factors, standard 12-lead ECG, natriuretic peptides, and echo have all been trialed, although have several inherent limitations. And therefore, there remains an unmet need for a non-invasive screening tool for detecting preclinical left ventricular systolic dysfunction in the community. Now, in a previous published retrospective study, we derived and validated an artificial intelligence-enabled ECG algorithm with favorable performance characteristics for the detection of left ventricular systolic dysfunction in patients with paired ECGs and echocardiograms. However, the ability of an AI ECG algorithm to prospectively detect left ventricular systolic dysfunction in a randomly selected community-based cohort remained unclear. And so that's where this work came about. And we really sought to assess the predictive value of an AI ECG algorithm for identifying both current and future left ventricular systolic dysfunction in a well-characterized large community-based cohort. Now, the initial cohort consisted of 2,041 randomly selected residents in Olmsted County, Minnesota. We then selected the participants that were at least 45 years of age. They had an NT-proBNP, an ECG, and an echo, and defined the echo, which was defined as a preclinical left ventricular systolic dysfunction, was an EF, or ejection fraction, less than 40% without any Framingham heart failure diagnosis, so the absence of clinical heart failure. And this resulted in a total study population of 1,996 participants with a fairly even split between males and females, and an average of about 40% of those over the age of 65. Now, we also wanted to assess the algorithm's performance in a high-risk subgroup, and this consisted of patients having at least one of the following: hypertension, coronary artery disease, current or former smoker, and or diabetes. Okay, and so that made up the high-risk subgroup, and that had a total of over 1,300 patients, 1,348, and of them, 42% were at the age or above the age of 65. Now, we then applied the AI ECG algorithm to the community cohorts ECGs and looking for left ventricular systolic dysfunction. Again, looking for that less than 40% ejection fraction. And this was done in both the total population as well as the high-risk subgroup. And so what we did here for the detection of preclinical left ventricular systolic dysfunction in the total population, you can see that with a prevalence in ours of 1%, the AUC for the AI ECG was 0.97, so very good. The sensitivity was 90% and specificity 92%. When looking at the high-risk subgroup, also another AUC of 0.97, so performing very well, and slightly better sensitivity and specificity at 92 and 93% respectively. So to give you an idea of what this looks like, let's take our community prevalence of preclinical left ventricular systolic dysfunction of 1% in that total population and 2% in that high-risk subgroup. Okay. Now, after running the AI algorithm, it detected 8.4% of patients that had a positive or abnormal ECG. And of these patients, 11.3% had left ventricular systolic dysfunction. And these results were actually similar in both the total population and that high-risk subgroup. Now, when we modeled an imputed screening program for preclinical left ventricular systolic dysfunction, where a positive AI ECG, so a positive one, triggered an echo, identification of one preclinical left ventricular systolic dysfunction case would require 88.3 ECGs that ran through AI and or 8.7 echoes that were done thereafter. And so that's in the total population. Looking at the high-risk subgroup, it was 65.7 AI ECGs that were positive that then triggered 5.5 echoes. Okay, so that's pretty much just to identify one case of preclinical left ventricular systolic dysfunction. Now, in addition, we surveilled the same population over 10 years, okay? So kind of looking for incident preclinical left ventricular systolic dysfunction. And the unadjusted hazard ratio for a positive AI ECG was 2.31 over that 10-year span for noticing an incident left ventricular systolic dysfunction. Now, despite the strengths of the work that we've just demonstrated, there are some limitations, okay? And that's why you have to interpret this work with some caution, especially when you're dealing with an ejection fraction cutoff values that are relatively low, because this results in a relatively small sample size. And so we chose to use 40% as that cutoff because it's a well-established guideline for threshold of initiating medical therapy in patients, even in asymptomatic patients with left ventricular systolic dysfunction. Now, in addition, this work was performed in that one selected Olmsted County population, so whether or not we can actually generalize this to other population and then communities is still really unknown. And that's where, there still needs to be a little more efforts. So the takeaways from this study that we've just shown here is that this is the first study to demonstrate that an AI ECG algorithm can actually identify preclinical left ventricular systolic dysfunction in a community cohort. The AI ECG model performs similarly well in individuals without heart failure symptoms and in that high-risk subgroup. In addition, it shows tremendous promise exists for AI ECG as a screening tool for identifying preclinical left ventricular systolic dysfunction. Now, in terms of next steps, future work should focus on multi-center, community-based validation studies that are large, okay, to further assess the effectiveness, the accuracy, and the economic implications of using AI ECG in clinical practice to identify left ventricular systolic dysfunction. On behalf of our team and Dr. Paul McKee, thank you very much for your attention. If you're interested in similar work that we do, please feel free to follow me for our latest work at the EKG Guy on Facebook or Twitter. Thanks again for your time.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.